myself, please welcome Dr. Rosanna Peeling. Thank you.
Thank you very much, Nikki, and I really like to thank the organizing committee of this conference for inviting me here. It's really great to be back in Canada amongst friends and get caught up with what everyone's been doing. Over the next 35 minutes or so, what I'd like to do is to go over with you the HIV/AIDS global targets and challenges in meeting them. I'm on the WHO expert committee on diagnostics, and we see a lot of problems in many countries still of getting people tested. There's been a lot of technological innovations in diagnostics in the last 5-10 years or so, mostly because we advocated for companies, big and small, to invest in diagnostics that are appropriate for the developing world. And so I'll be taking you through some of those. And then after we have these products of innovation, we actually need innovation in delivery mechanisms, because many countries don't have, are not as fortunate as Canada to have really good infrastructures for delivery of diagnostics. And I'd like to say that just disclosure of, I do not have any conflict of interest, and when I mention companies, it does not mean that the London School endorsed them, nor the WHO. Now, the global targets have been set at the United Nations General Assembly in 2011. And it was estimated that we would need about $22 million in order to place 15 million people on ART. And the target is to, by 2015, reduce TB deaths among people living with HIV by 50%. And we like to eliminate the mother-to-child transmission of HIV. And in some regions, such as in the Americas, there's a joint elimination of mother-to-child transmission of HIV as well as syphilis. And we also like to be able to intensify HIV transmission. This is a slide that I actually took from the head of the WHO HIV department. He made a presentation to the expert group on the progress towards ART coverage in the last few years since 2003. So it seems it's very promising that we've actually increased the patients receiving HIV from 3% to 47%. But we still have a significant gap in getting another 53% of patients that are estimated to require ART on treatment. And we also realize that an estimated about 11 million HIV-infected individuals have no access to CD4 counts, so they cannot actually be eligible for treatment, and that's part of our problem. Now, this is taken from the publication from the Treatment 2.0 initiative that WHO and UNAIDS is advocating. The goal is to achieve and sustain universal access and maximize the preventive benefit of ART by doing 5 things: optimizing drug regimens, of course, but also promoting diagnostics at the point of care as much as possible and using very simplified algorithms for getting them used. We need to overall reduce costs, because at this time of economic crisis, who has $24 billion they could spare? We need to adapt delivery mechanisms to make it as easy as possible in health systems that are very, very fragile or broken. We need to mobilize communities and continue to advocate for human rights. Now, when we come to the strategy, we realize that much of it depends on diagnostics for getting people tested, for monitoring what they're doing, for looking at co-infections like TB, like HPV and HCV, and also in pregnant women, getting them tested. And so if you look at the whole program, we have these questions that we ask. What is it that we could introduce into these systems? How will we introduce them? And when you have new technologies, do these countries actually have a mechanism of assessing these technologies and say, within our country, at the point of the epidemic that we're in for HIV, where should we deploy these technologies and when can we start? There are many, many priorities often in developing countries other than HIV, and like clean water so that children don't die from diarrhea, there's malaria, etc. So there are many, many competing priorities, and trying to get diagnostics into these systems is actually quite a challenge. So what we wanted to do in the short term is to establish areas of optimization for early infant diagnosis, CD4 and viral load, and also establish operational guidance on how to deliver those. In the medium and long term, we'd like to be able to ask industry if they could actively develop products that would be useful, especially in bundles or as duplex tests, so that it simplifies the way that the diagnostics can be used. But it's quite often very difficult to ask companies to start on development of a new platform or a new diagnostic when it's very costly and there are many risks. And then at the end, when they have a good product, we turn around and ask them to donate it to the developing world. And so that's a non-starter right there. So we need to find good business mechanisms that would allow us to do the stimulation. Now, in terms of the bench to bedside pathway for development of diagnostics to getting them used, you could see that along this pathway, the R&D quite often, depending on whether you have an entirely new platform or you're using existing platform, the development quite typically takes between 2 to 10 years. For example, many of you may be experienced with the Cephid's gene expert platform, which has now become available for TB and rifampicin resistance. That platform took about 11 years with lots of money from the US government because it was after the terrorist attack of 9/11 that the government realized that they need some very, very highly accurate technology to rapidly detect agents of bioterrorism. So Cephid was one of the companies that received that funding, and now they've come up with a really good platform that could give you highly accurate TB diagnosis and rifampicin resistance in an hour and 45 minutes. And it literally can be used at the point of care because you just put the sputum in and walk away. Now, so that took about $120 million and 10 years' time, 11 years' time. So we're now at the proof of principle stage, and they've gone through a lot of field trials. But if you look at downstream, regulatory approval in most countries take between 2 to 5 years, and especially when it's an imported commodity. And then policy and uptake takes another 5 to 7 years because policymakers quite often would like to see a lot of evaluations in the field, and also they like to see systematic reviews that would tell them that this is actually a useful test. And then even after the 5 to 7 years, even when the test is on the ground, there are quite often in the developing world problems with quality, maintaining quality of the test, quality of the test system, as well as supply chains. Now, so if you think that for TB, what we are facing with in the world today is 1.8 million people die each year of TB. And right now, the Gene Expert platform is available it would still maybe take another 7 to 10 years before they could be widely used in the developing world. And so 18 million people may die before we figure out how to get them approved in the system as well as the uptake. So this is a scenario that we hope that we could start to work together and shorten or have some other means of making the innovation of delivery work for the developing world. Now, with regard to regulation of diagnostics, when I was in WHO, we did a survey of the 191 countries that was in the UN system at that time, and 85 countries responded. And out of the 85 countries, over half of them do not regulate diagnostics. And you could see within the different regions, for example, in Africa and in Asia, in the Western Pacific region, many countries don't regulate diagnostics. And even in those that do, the standards for how they're evaluated in terms of safety and effectiveness are different. So we have now this scenario that is very, very challenging for us to introduce diagnostics into any country, because regulatory regulations are very highly variable from country to country. The approval process takes a long time, and also it's not transparent. Companies find it very hard to get information for each country that they want to apply to, what they need to do in order to get approval. A lot of approval processes don't have good standards, and there's limited success in terms of harmonizing regulations so that companies wouldn't have to do so many tests, so many clinical trials. So the scenario is that tests are sold and used in much of the developing world without any evidence that they work. And these are in countries that don't regulate diagnostics, where you just pay and register and then you could sell. And companies with good tests are unwilling or unable to compete in markets that are flooded with bad tests, because low quality tests tend to be cheaper. And now in one of the companies that have the first point of care CD4 test, this company is having to go through 29 trials in Africa alone and 42 around the world. This company originally targeted their point-of-care CD4 test at $6 per test. And because of all these trials that they have to do around the world, the last quote that we got from this company from Tanzania is that they are charging the Tanzania national government $35 per test. And that makes the Tanzanian government feel very difficult. How can they roll out a test for CD4 at $35 when they have so many other priorities? And the average cost of the average health dollar per person spent in Tanzania is around between $4 to $6 a year. And so we need to do something about harmonizing regulatory approval. The other thing that may sometimes affect Canada as well is that companies then, because of all this complexity and also the costs of regulatory trials, just don't bother to target smaller markets. And for some diseases, Canada is a smaller market. So what we found is that in many countries in Latin America, I just found this out at our Brazil meeting, they have to pay as much as 4 to 6 times the price for some commodities, because they have to go through many layers of middlemen in order to access the diagnostic from these companies. And also, so a test that would be that would cost the Canadians between $4 to $6, they're having to pay about $30 because of going through the middleman, not because of the cost of goods. And so Grand Challenges Canada, together with the Gates Foundation, has commissioned a number of us to actually look at this challenge. Now, I'd like to go through with you some of the new technologies that are coming along. And so first amongst them, there's been a lot of discussion at this meeting about oral tests versus blood-based tests. And we all know OraSure have been working for years on an oral test for HIV as well as for HCV. And Nikki has actually done a systematic review of the many publications on oral fluid versus blood specimens for HIV testing. The bottom line is, although the pool sensitivity and specificity are pretty equivalent with the two types of specimens, in a low prevalence setting, the positive predictive value is of concern to those of us in those settings where you're looking at very few, probably very few real positives amongst maybe a lot of false positives. Now, we also are concerned about the fact that you could actually, off the internet, you actually have advertisement like this about home testing. And quite often these advertisements include all kinds of approvals from the FDA, from the EU, et cetera, et cetera. But because what you do with a lot of these internet testing companies is that you just pay and you send your specimen in, and then you get an answer back. You really don't know what tests they do, how they do it. It could be, somebody's kitchen where they just do this on the kitchen table. You have no idea. But of course, because of the nature of STDs and HIV, confidentiality, stigma, etc., these are actually well subscribed. And so we're concerned because we've bought some of these tests and they actually don't work. Now, what of CD4 technology? I think in Canada you're very familiar with the big equipment that has been around for years now. The BD fax caliber is a really good test, and but it costs about $75,000 to buy the machine. But because of batching, it's between $3 to $7. And then CAHR also have an equivalent machine. Now, as there's a demand for smaller machines, Partech has got a machine that is only $27 and also about $3 a test. And it still gives you a turnaround of 60 minutes and can do about between 200 and 400 specimens a day. So this is in a high throughput setting. Now, for the developing world, companies have responded and started to downsize their machines with lower throughput so that we could put the machines into lower levels of the healthcare system. And so these few machines are can do less than 50 samples a day. And typically, the time has now been reduced to about 35 to 45 minutes for each test, and the costs remain at $3 to $5 because of batching. Now, when we then ask companies to actually have portable cytometers, they've responded with smaller machines that could turn around the results in 8 minutes, and is less expensive. And the one that I was telling you about that's commercially available now, that is really point of care, is the one that's made by Alair. It's called PEMR. And it's now the machine is only about this big, and it's $6,000. And the original target was $6 a test, but now it's any range between $6 and $35. The good thing about this machine is that the cartridge is very small, and it includes the lancet. So you literally touch the cartridge to the fingertip of the patient, and it would extract the blood. So there are no external supplies needed, no capillaries, etc. And then you could just lay it down on the bench for 20 minutes. and then you put it into the machine to read. And because the reading just takes seconds, it's very energy efficient. So that machine can use battery power. You could actually plug it into your car battery. It could use solar, etc. And so that is now a truly, point-of-care device. And we wish that the company would actually make it available widely, but there's, of course, problems with getting regulatory approval, as I mentioned. Now, what's in the pipeline? UNITAID is a UN organization that gets its money from a small taxation on airplane tickets. They've actually mapped the pipeline, and there are a number of truly point-of-care devices that are coming up in this year and next year. And a lot of those point-of-care devices have been funded through the Gates Foundation CD4 initiative. And there are machines that have a reader and, as I said, also a cartridge that includes the Lancet. But there are also there are also tests that don't require a machine. For example, the Siomics test is literally like a dipstick test. And it needs a small spinner tool, but that's not like a reader at all. And it's semi-quantitative, and it requires reading by eye, and so that may be one of the limitations. They're still to be evaluated. MBio is a small company in Colorado, and they have not only an HIV, CD4, they also have HCV, and it's all done in a small reader that allows you to take a picture of the test for quality control as well. And for viral load, unfortunately, we don't have point-of-care technologies available yet. And also for infant diagnosis, we're still requiring a small machine or a large machine, and there won't be any new ones that would be available until late 2013 and 14. Now, one thing that I want to say about this new platform that's freely available is that the company has now a whole lot of menus of tests that can run on this machine, including they already have MRSA available, they will soon have viral load available, and they're looking at other C. difficile and other applications. And they could sell machines that are small or big, depending on your throughput. And also, what's new about this platform is that it's random access. So you don't have to have a batch of TB tests and then a batch of HIV tests. You could actually put in a TB test in 1 minute, and the next minute, if a person comes along and you need to do chlamydia and gonorrhea, you could put in that one, and then another one 2 minutes later. So each unit is a complete random access. And also, you no longer need to have a technician come and do maintenance on these machines. The company has evolved a system where they could send you a quality control cartridge, which you then put into the machine. You run the machine, and it will tell the company whether all the parts are working well. So this is a new way, a new generation of tests that in terms of point of care is very reassuring in that you no longer need to have a service contract with the company having to send out thousands of people into all different healthcare settings to do maintenance on these machines. And so right now, there's still a problem with the cost of these tests for the developing world, because right now the company is putting as a developing country price $16 per TB test, and in the developed world it's $65. So there's a big price differential. And for viral load, they haven't actually put those prices down yet. And so we're expecting that as they develop many menus of tests along this platform, that the cost of each test will become cheaper and cheaper. So in terms of efficiencies and economies, what we like to see is HIV, TB, hepatitis B and C all multiplexed into the same test, or that if you need to do crypto or other diagnosis, that it could be bundled even if it's not the same test. And also toxicity monitoring. The opportunity is now that we could actually tell the developers what we want and what we do. So I would be very interested to hear from all of you what is it that we could bundle, we would like to see bundled, and what we would like to see in the same test. Because if you require different specimens, obviously you cannot put them into the same test. But if you require, if your testing interval for different tests are different, then it doesn't make sense to have them multiplex in the same test. So we're still trying to figure out in many countries what would be the most optimal package for bundling and multiplexing. There is now, I just came from Brazil, as Nikki said, and the Brazilian government has actually paid $4 million for this new technology so that they could have the technology transfer and local production of this technology in Brazil for the public health system in Brazil. The idea of the dual path technology is that instead of the single lateral flow device, which actually has problems with many complex molecules competing to bind to target ligands, is that if you have a separate path for specimens and a separate path for your reagents, that you get a cleaner interaction between the antigen and the antibody, and it would increase the sensitivity of the device by between 10 to 15%. And with this also, there's the opportunity to put in multiple bands. So right now they already have a test that is for HIV, HCV, and syphilis. And there's the opportunity also with the Brazilian government having this non-exclusive license to actually be able to apply this technology to parasitic diseases and other diseases that are important in the Latin American region. There's also, last July, a lot of press about this new test, which is MChip. And literally it's the size of the credit card. You could hold it in the palm of your hand. It's a first ever commercialized microfluidic device for infectious diseases. And it has many, many fine channels. It would work great with blood, but there's going to be problems if you have a complex specimen like sputum to get it through those channels. But also there's a challenge of getting enough specimens with enough target into the system. So there has to be a concentration step up front as well, and it's read with the machine. So this is still, this has undergone evaluation in Africa, but it still needs further evaluations. And they have an HIV and syphilis combo test, and it's going to be less than $1. Now, with all these new technologies, especially if they're read with the reader, then there's the opportunity to put into the reader the connectivity to a central database so that you could, even though you decentralize testing to huge areas around the world, you could actually have them beam up the results into a cloud or into a central database if it's all compatible with each other. And you could capture epidemiologic information and use it for surveillance very effectively. And also with these readers, you could actually put in a GPS so that you could pinpoint the location where the data source comes from. And so rapid tests or point-of-care tests allow better linkage to care, because the results are immediate, they're right in front of the healthcare worker and the patient. And so that's been shown in Mozambique, in a lot of countries, that point-of-care devices actually make a lot of difference to linkage to care for HIV-infected individuals. Because I think in a study that was conducted in Mozambique and in Kenya, they found that 40% of the patients who tested positive for HIV are lost to follow-up. They never come back for their CD4 because they are scheduled for, months later, and they just forget about their appointment or they don't bother to come back. But having a CD4 test available at everywhere where you test for HIV would really make a difference about linkage to care. And then also, the whole electronic system of capturing data that is still to be exploited. And I think that it is going to be a really different way that we think about using technologies to diagnose and to think about policy for care and treatment. Right now, in South Africa, the national healthcare system is actually mapping out where their health labs are and where the TB cases are, and then actually using a very evidence-based system to place the point-of-care devices, the gene expert, so that they could capture and the national picture a lot more accurately. And also, as disease prevalence goes down, then they could actually then trim down the way that things needs to be done. And because the platform allows them to use the machines for viral load as well, and so there's a lot of flexibility once you place these machines on how to use them. Now, what's on the horizon? This prize for a tricorder, for those of you who are Star Trek fans, a tricorder is what we all want. And because I think, as I recall, the tricorder not only diagnoses your condition, but actually can repair your DNA so that you are better right away. Well, we're not thinking about that. We're just thinking about the diagnosis part. And so there's a prize of $10 million for those of you who are, into gadgets and development of new apps. $10 million for the person who could have a tricorder that would diagnose 15 conditions, but it has to weigh less than 2.2 kilos. The Bill and Melinda Gates Foundation and Grand Challenges Canada has also started a point-of-care initiative with the goal of developing an open point-of-care instrument platform capable of delivering optimal performance, and also to try to get the machine to be as interoperable as possible so that different companies can actually develop tests on an open technology platform. And also try to encourage a harmonized regulatory environment so that this platform can be quickly approved for use. So the idea is that they funded 24 grantees to develop, some to develop platforms and some to develop devices. And it's to be so interoperable, the analogy that you could think of is that right now you could buy a memory stick from any company and you could plug that memory stick into any computer and it would work. So in maybe 5 years from now, what we hope is that there'll be a number of these so-called base stations that it's open access for any company to develop tests on these. Because if you think about the etiology of different syndromes, such as fever, they are different from different parts of the world. In the past, funders have said, we will have a prize for the person who could develop this fever stick to look at causes of fever. But one stick does not fit all, because the cause of fever in Asia is quite often dengue and lepto. malaria is not as one of the top. But in Africa, malaria is the predominant cause of fever, typhoid, etc. So to have this flexibility of being able to, whatever your disease epidemiology is in your country, to put the right menu of tests for a patient coming in would be great. And also, these platforms can be used by anybody and anywhere. And the platform itself is just a detection and transmission device. And so the specimens actually never go into the platform. The specimens are contained in the cassettes that are clicked into the platform. So think of the memory stick as your detection, as your sort of PCR test, and the platform as the device that actually allows you to detect a signal. And so in about 5 years from now, we will have this new generation of tests that could be used at all levels of the healthcare system at a fairly low cost. So we're hoping that with that, we could actually look at how we can maximize the potential of these new tools. With the Treatment 2.0 strategy, we were trying to simplify the way that diagnostics are used in the developing world. We're aiming for decentralizing as well as integration of different services so that you don't have an HIV patient having to go to a different place to get TB care, a different place for other healthcare needs. And we like to very much so to support community-based testing because these technologies are now possible. It's now possible for us to use them everywhere. In fact, some of the people I talk to would like to say, maybe we could purchase one for use in the home for people who have multiple needs for daily monitoring. And so it is possible because a lot of these devices will be literally maintenance free. And so with all this, we'd like to somehow come down to a very affordable price for everyone. Now, with all the technology that's being developed, what we're lacking in the developing world is that we're often trying to put these technologies into health systems that are not functioning or really fragile, so that if you put services into one area of the health system, another area breaks down. And so we've seen that with some of the countries that receive Global Fund or PEPFAR money, where then all the healthcare workers who are really skilled all go to work for PEPFAR programs, and the rest of the country are left with no one to give very basic medical care at primary healthcare level. And so what we like countries to start to do is to think about setting up a national committee for diagnostic technology assessment. And then with every new technology that comes along, you say whether for our country, with our disease burden, with our healthcare system, is this needed or not? And then if it's needed, where would we deploy them for maximum gain? Thailand has come up with such a system. So they have a program called HITTAP. It stands for Health Intervention and Technology Assessment Program. And they would take every new intervention that comes along. For example, the latest that they've done in about a year and a half ago was look at oral HIV tests versus blood-based tests. And after consulting with all levels of the healthcare system, doing some mathematical models on cost effectiveness, as well as consulting with civil societies, they had turned down the oral test and said that Thailand would not approve the oral test for registration in Thailand. And they also did assessment with the HPV vaccine, because it's Thailand has a universal healthcare system, so the cost of the vaccine is going to be very important if they decide to adopt them or not. So with many new diagnostic technologies coming along, we need these sort of really evidence-based way to introduce the systems. For example, WHO in the last 5 or 6 years has endorsed 4 different new technologies for TB. And countries are confused, do we take all 4? Do we take 1? Do we take 2, 3? And where do we put them? There isn't a system in place in many countries to do that. And we would like to work with countries like Canada, the US, and Thailand and South Africa to actually start to come up with these models of technology assessment and appropriate placement. Because what we like to see is not only to think about the public system, but in many countries, the private system as well as look at patient behavior and as well as throughput, because there are many communities that would like to have certain technologies. And this is a slide that I use for my presentation at the WHO to say that, when you have a very good technology like the plane, you wouldn't put the plane into a village because there won't be an airport there to receive the plane. Nor could you put a train where there aren't any tracks, right? So this thinking about appropriate placement of new technologies is very, very important. And quite often, this is not sexy, so donors actually don't like to fund this kind of work. They like to fund technologies that would make the news, such as the MChip, that for $1 you could diagnose, 10 diseases, or the atricorder, etc. So now, along with that, what we've started in the school is that we've seen that in a lot of countries, because HIV and other sexually transmitted infections are quite often stigmatizing to patients or at-risk populations. And in some countries, homosexuality and sex work are illegal anyway. There's a real barrier to putting the technology into the hands of those who really need them. And so I started to think about a social entrepreneurship program with the World Economic Forum and with different programs such as at the CDC in the US, as well as at the University of Hong Kong. There's a program for technology and society. So we started a collaboration to look at social entrepreneurship for sexual health. And the idea is to overcome the dominant paradigm of providing services only through the public clinic and through vertical systems. But in fact, we like to empower communities to think of how they could run a social business using social business principles or entrepreneurship principles, where you run a nonprofit business to provide services for at-risk populations, make it very user-friendly, but the profits plow back only into the business. And we have assembled now expertise in terms of how to run social businesses from the World Economic Forum. We will provide the technological upgrades for each one of these models, as well as we would put them together with other community-based groups to share experiences. And this work is now ongoing. I have a PhD student who just started to work at this, and we just got a concept note published in PLOS Medicine about this new paradigm for service delivery. So I also look forward to whether we could collaborate on this. So in summary, I think that we've come to a point now, not only is the HIV epidemic come to a turning point, but we've also come to a turning point about technological innovations. We can now think very creatively about how to use these new technologies for our healthcare delivery. And we need to think outside of the box in terms of not thinking only through the traditional public health system and centralized vertical delivery systems, but much more community-based and need-based delivery of services. And we really need to think about how to monitor quality, because quite often as you decentralize testing outside of laboratories, you need to set up a separate way to monitor the quality of the testing as well as the quality of the tests when they are stored outside of, at very different temperatures than inside a lab. And we need to think about what would be the ask that we ask of companies in terms of bundling, in terms of multiplexing. So I'd like to end by thanking you all, and I look forward to our collaboration. Thank you.